All right, everybody, welcome back to another episode of the Fearcast. This is the podcast dedicated to OCD and anxiety spectrum disorders, and getting your life back. I'm your host, Kevin Foss. I'm a licensed therapist specializing in OCD and anxiety disorders, and thank you all so much for hanging out with me today for this episode. So this is a bonkers long episode. I don't know if this has beaten the record of the longest episode, but it's a big one. It's a lot of information. So let me tell you about that in just a moment. But first, if you are new to the podcast, this is a question and answer-based podcast about OCD and anxiety disorders. If you have questions about those things, go over to fearcastpodcast.com. Shoot me an email over there. You can also, you can send your question over there. You can also click on the little speak pipe button over there. Send me an audio question. Audio questions go to the tippity top of the list, as do questions sent in through Instagram. I'm Fearcast Podcast over at the Instagrams. And you can send me a DM, record your message over there, or just record your message and email it to questions@fearcastpodcast.com. Because it's question answer based, it is run by y'all. What questions I get, those are the questions I answer. So wherever we go, whatever interest is out there, that is the stuff that we're going to be talking about. So, but for today, I have an interview. I interviewed Dr. Sanjaya Saxena. He is a psychiatrist and specializing in anxiety and OCD, or OCD and anxiety related disorders. I'll say a little bit about his bio in just a moment. But if there are further questions that y'all have, send them over to Fearcast Podcast. I'll try to wrangle him in back on to answer some specific medication questions. But I'm so appreciative of Dr. Saxena's time for sharing all sorts of information about medication. Medication is one of those things that people ask about a lot in OCD and anxiety treatment, especially if they're calling me to talk about behavioral work, so CBT and exposure and response prevention. They're also going to ask questions about medication. And because I'm, a lowly therapist and not a psychiatrist, I don't prescribe medication, and I tend to not give specific advice or guidance about medication. So it can feel like a bit of a mystery, and a lot of people are either really interested in medication or they're really turned off by the idea of medication. They're just afraid or confused about medication treatment as it pertains to their overall treatment for OCD and anxiety. So I'm so appreciative for Dr. Saxena to share his knowledge and wisdom this matter of fact, encouraging kind of demeanor he has about the whole thing. So you'll hear it in just a moment. But let me tell you a little bit about him, and then we'll just jump right into this episode to not make it any longer than it is. So Dr. Saxena is an internationally known board-certified psychiatrist who specializes in OCD, hoarding disorder, OCD-related disorders, and anxiety disorders. He is the director of clinical and research affairs of the International OCD Foundation, so the IOCDF. His clinical practice is in San Diego, or is the San Diego Center for Obsessive, Compulsive, and Related Disorders. And he's the clinical professor, and he is also a clinical professor at the UC San Diego Department of Psychiatry. And an interesting point that I want to add about him in reading his bios, Dr. Saxena also served as the psychiatric consultant for the movie As Good as It Gets, a 1997 movie in which the lead character, played by Jack Nicholson, suffered from OCD. So I knew that they had a really good consultant for so they could portray OCD in a accurate and respectful manner. But I didn't know it was him, so I learned something new today. So I hope this interview has been, or it is helpful. I just got done chatting with him. It was amazing. So without further ado, here is my conversation about medication for OCD and anxiety disorders with Dr. Sanjaya Saxena. All right. So, Sanjaya Saxena, thank you. Or Dr. Sanjaya Saxena, excuse me. Let me just welcome you to the Fearcast. Thank you so much for joining us today to talk about your expertise with medication as it pertains to OCD and anxiety treatment.
Thanks so much for having me, Ken.
Of course, of course. Well, so I've got a bunch of questions to go over. I know a huge question we get in treatment is how, is medication necessary? Should someone immediately get on medication? Is it going to work? Is it not going to work? How do you find the one that's going to work? So I wanted to just put together a little bit of a resource for folks if they have questions about medication for treatment to go over that. So I appreciate you coming on to share a little bit about that. And I'll say for everybody, this is not medical advice specifically for you necessarily. This is a guidance information so that you can talk with your provider about this. Would you say that's an accurate way to start this out?
Yeah, I think so. I mean, I think those questions that you mentioned are, the typical and most common ones that people with OCD or other disorders have just on their own, and specifically when they meet with a psychiatrist such as myself for treatment. So I think it's useful to kind of spread understanding of how we even frame those questions and how we go about answering them. So, from the first question of what's the diagnosis and what treatments are best for that particular diagnosis or that combination of syndromes or diagnoses that's present in the given individual, because usually there's more than one. OCD rarely occurs in a vacuum. It's almost always accompanied by other anxiety disorders, other mood disorders, OCD-related disorders. So when we as treatment providers are going through this thinking process of trying to figure out what treatments would be indicated, what would we most recommend for a person, what combination of treatments would we most recommend, we're thinking about it in this sort of framework of the very first part is doing a really solid evaluation to understand the nature of the disorder, the severity of the symptoms, how much impairment somebody's suffering, what's the breadth of their different syndromes, of the different diagnoses or disorders that might be present that they're suffering from, which are more important, which are less important, what's more severe and impactful right now that the person really needs to focus on for treatment, and what may be a background chronic thing that's not really so bad right now, or maybe is in the stages of getting better, right? And then getting more into the specifics of, okay, are we going to do medication? Are we going to do it alone or in combination with CBT or another treatment? Secondly, which medication, right? So going through those questions about which ones are indicated, what would be our first line medications, what would be the second line medications, what would be the potential add-ons or adjunctive medications that are sometimes used as boosters, and then so on. So a lot of that depends on not only on what the person is presenting with, but also their prior history. Right. So what they've been on before, what worked, what didn't work in the past. Did they receive adequate trials of the medications at doses that were in the kind of therapeutic range that we would expect to improve OCD symptoms? Or did they never really get a full trial because they were always kind of underdosed, or maybe the duration was too low? Did they have significant side effects on particular medications or classes of medications that would impact our decisions about what to try next, right? We don't want to try something in the same class when somebody has already tried 3 or 4 of those and they either didn't work well or they caused really problematic side effects. So, and did they respond to particular combinations in the past? Are there other medical conditions, substance conditions, other factors physically that would influence our decision about which treatments to try, which treatments would be contraindicated? Is there family history that's informative in some way? Because sometimes if people have siblings or parents or other close relatives who have very similar profiles and presentations, and maybe they have really responded well to a given medication, since there's going to be biological similarities, we might think, okay, yeah, if that worked for your sister who had very similar symptoms to you, maybe it'll work for you as well.
It's likely that it might work for them too, yeah.
Yeah. So we look at a whole range of different factors, and that's why the broader, more comprehensive diagnostic evaluation is really important, because you can't make the decision based on one factor. There's a whole series of things that have to be put together that will result in a treatment plan that's kind of tailored for that individual.
Yeah. So it's not just a one size fits all. Go online. People talk about SSRIs. So they come in gung ho. I've got to get an SSRI. Right. Okay. Yeah. So this is it's a multifaceted assessment process. So it's not just going to be this one throwing something at you. So to that end, one of the questions that I've heard, and I know that I've heard this as something that's been developed or something that is currently in practice, a genetic test that you can take to kind of get an idea about what medications may be more effective for you. I imagine you're aware of something like this. What are your thoughts on that process, and what's the current state of that as far as you know?
Yeah, there is genetic testing out there. GeneSight is one of the companies that does it. Overall, the results that you get from those are not necessarily valid predictors of treatment response. So I think when you look at the results that they give to people, they kind of overstate the case. Mm-hmm. The fact is that most of the findings that either predict better or worse response in relationship to having particular genotypes or gene variants are not really that valid, and they certainly are not valid for OCD. So much of that research has been done in treatment of depression. Very little of it done for treatment of OCD or treatment of anxiety disorders. So it doesn't always apply. And groups have come out with sort of consensus statements saying that basically it's not ready for prime time. That they can be suggestive, but the predictive value of those is not great. And sometimes the results will put a medication in the red column, and the patient says, "Oh no, I can't take that. It's in the red." Mm-hmm. And the fact is, they've actually done well on it, or it's one that they're already on that they're doing fine on, and vice versa. There might be one in the green that they had bad side effects to. So I think the findings are generally overstated, and most psychiatrists, at least in the who focus on OCD or anxiety disorders more broadly, will tell you the results are really not all that predictive. The one type of genetic testing that comes with those results that can be helpful in certain situations are what we call the pharmacokinetic gene testings. And those are the genes that test for the enzymes that break down or metabolize the medications. And they can be of benefit in cases where somebody is getting a lot of side effects, even to microdoses, tiny doses of a number of medications, where we think that, okay, maybe they've got slow liver metabolism of this metabolic pathway. And that might be why we're starting out with a tiny dose and they're still getting bad side effects. Or going the other way, maybe they've been on high doses and haven't responded and they barely feel any side effects at all. And we're wondering, do we need to keep going higher because are they a very rapid or ultra rapid metabolizer? So maybe they have the gene variants that code for really elevated liver enzyme function. And actually what we need to do is keep pushing up, because otherwise they're not even going to be in the therapeutic range because they're chewing it up and metabolizing it so fast. But those are sort of extremes. For the vast majority of people, they're going to be in the middle, right? They're going to be in somewhere in the medium, usual, normal range of drug metabolism. So those tests I only usually recommend those when there's a particular problem, where we're noticing that somebody hasn't responded well to a number of different agents, or they've had really bad side effect problems at low doses. Then we want to kind of figure out what's going on there.
Yeah. I've had one of these clients as well where they started on a very, very little dose and they had just a tremendous amount of side effects and causing them to just say, I'm not even going to take it, when their treatment could have benefited as others have in medicines or from other medications.
Yeah, so the kind of the take-home message that I send to people is that there's no single gene and there's not even any combination of common genes that really predict well whether a given medication or class is going to work for people with OCD. And the GeneSight testing is somewhat more helpful for people with depression or other disorders where there are multiple different classes of totally different kinds of medications that you might be able to choose between, right? So if SSRIs are contraindicated, okay, well, you've got 3 or 4 or 5 other classes of antidepressants that might work, and maybe the testing would help. With OCD, that's not a factor, right? There is only one class that's a primary medication group for OCD. Anything else is used as an adjunct or a secondary medication. Right. So you don't have the flexibility of saying, oh, well, if SSRIs aren't good, let's just move to the other, first-line treatments, because there aren't other first-line treatments. Everything else is either second-line or adjunctive.
Right, right. So that, and why don't we jump into that? So you talked about, first line treatments and then, other secondary supplemental treatments. So why don't we start with what is considered a first line treatment medication wise for OCD? And I guess, should we broaden that out to anxiety disorders as well? Or is it specific to OCD?
Specific to OCD, yeah. So many of the medications do work for other anxiety disorders, but the pattern is often different. And OCD has sort of a narrower range of medications that have been shown to be effective. So there might be a couple different classes of medications that have been found to be effective for generalized anxiety disorder or for panic disorder. With OCD, there's really only one category of first-line evidence-based gold standard medications, and those are the serotonin reuptake inhibitors, SRIs. They include the more selective ones. So if you hear the term SSRI, that refers to selective serotonin reuptake inhibitors. But even one that's less selective, a tricyclic medication called clomipramine or anafranil, is also a highly effective medication. So the typically commonly used SSRIs include escitalopram or Lexapro, citalopram or Celexa, sertraline or Zoloft, fluoxetine or Prozac, fluvoxamine or Luvox. Right, so there are about 6 or 7 SSRIs currently on the market, available in the United States. Most of them are either FDA approved for OCD in the U.S. or abroad. Right. So it doesn't really matter whether you're using one that has an FDA indication in the U.S. or not, because the efficacy overall, if you look across broad populations, they all work to about the same degree. There might be 1 or 2 that are more beneficial for a given person than the others. So there is a value of, if somebody doesn't respond to the first one you try at a full dose, okay, then switch and try one that's a little bit different. They're not identical. They're in the same family, but they're sort of cousins of one another. So they may share their primary mechanism of action, but they also have some differences. And they hit slightly different receptors from one another. They have slightly different patterns of side effects. Some are a little bit more initially activating, so we might give them in the morning, and they're better for people who are feeling a lot of fatigue during the day. Others are a little bit more initially calming or even sedating, so we might give them at nighttime, and they're beneficial for people who are having more sleep trouble or are feeling really wired and unable to relax. But if you look 12 weeks out, 24 weeks out with chronic treatment, they all look roughly about the same across the population.
But that's more... go ahead.
Yeah, so I'm saying, so those are the first line. Those are really the only medications that are considered first line or front line effective medications when used by themselves for OCD, either by themselves or in combination with cognitive behavioral therapy. It would be the SSRIs and clomipramine.
Yeah. So interesting what you said is that so if I heard this correctly, is that they kind of start out that they're selected because of the other ways that they affect the individual. So, but as they go on, they kind of level out into having similar effects. Did I hear that correctly, or is that?
Well, the selectivity, it just has to do with the main binding profile of the medication. So they're called selective serotonin reuptake inhibitors because they preferentially bind to the serotonin reuptake site, the serotonin transporter. But that's usually, the word selective is a little fuzzy because almost all of them have other effects at either other reuptake sites, like sertraline or Zoloft is also a dopamine reuptake inhibitor, right? Paxil, or that's the other one I forgot to mention, paroxetine or Paxil. Paxil is also a norepinephrine reuptake inhibitor to some degree, and they all have effects at other receptor sites as well. So they're really not as selective as the drug companies would have you believe, which is why I generally just use the term SRIs, not SSRIs.
Fair enough.
And clomipramine is in a different class. It's a tricyclic antidepressant, but it's the only one of the tricyclic antidepressants that is a very, very strong serotonin reuptake inhibitor in addition to its other actions.
So you mentioned earlier about, some people complaining about medication or having struggles with medication because maybe they didn't have an adequate trial of that medication. Can you talk a little bit more about what that means and what an adequate trial would be?
Yeah, and this is a really important point because Certainly lots of people with OCD, their family members, and also clinicians, including psychiatrists, don't understand that the doses of these SSRIs and clomipramine that are required for optimal treatment of OCD are often 2 to 3 times higher than the doses that were typically effective for depression or panic disorder or general anxiety disorder, right? So you have to get up to the proper dosage, and that's often going to be 2 to 3 times higher than what's used for depression. Secondly, the duration is longer. So in order to have a full trial, you usually need to have a good 10 to 12 weeks with maybe at least half of those weeks in the therapeutic range. So for example, the doses of fluoxetine or Prozac that are often effective for depression might be 20, 30, 40 milligrams a day. For OCD, you often need 80 to 100 milligrams a day, right? 60 at a minimum and often up to 80 and sometimes even higher. For sertraline or Zoloft, 50 milligrams a day, 100 milligrams a day might be effective for depression. For OCD, you usually need to be above 200 and often 300 milligrams a day. And the duration, instead of knowing within a couple weeks whether it's going to be effective, you really have to go out. Number one, it takes a while to build up gradually up to the effective dose. And then secondly, you have to be on an effective dose in that range for a good 6 to 8 weeks before you really know whether it's going to work, because improvement is often slow and delayed.
Right.
So when people first start on these medications, what they may notice within, the first couple weeks, 3 weeks, might be some improvements in mood, some improvements in general anxiety and tension, maybe some improvements in sleep and appetite. The OCD improvements don't always start that early. Right? Occasionally they'll start early, but oftentimes you have to wait. And you have to get up to the higher doses, and then it starts kicking in somewhere, after a month or 6 weeks or 8 weeks. And then it can gradually build and build and build and build. So it doesn't really plateau until you're maybe 3 months out.
Right.
So it's a longer process.
Yeah, it's a longer process. And there's so much... people get demoralized in that process. It's just, they start taking this medication, and if it takes up to 3 months before you really start to see those effects, I mean, that's a long time. So I hope people hear that, of just continuing on in that process and just giving it a go, because you hear stories about people trying it for a couple of days and just going, I don't see the effect, or even a couple of weeks and just going, no effect, I'm done.
Yeah. And that's just way too early. Usually you'll start seeing something within the first month, but then it'll build. And so you really don't know what the full effects are going to be until you wait. So it does require patience. So we always educate people and their loved ones that this is going to take a while for us to even know whether this medication is going to work, because it takes a while to get it up to the full dose and then see what effect that has. So you have to wait for a while. You can't just sort of quit, like you said, after 2 weeks or 3 weeks. Secondly, because it's going to require higher doses in most people, that means you're going to have more side effects. So
let's talk about those side effects. Yeah,
they're the rule, not the exception, right? So we're dealing more with managing the side effects and mitigating the side effects, as opposed to thinking that this is going to work without any side effects. Right? Most people will have common side effects. All these medications have pretty typical common side effects. Luckily, most of them wear off after a while. So you see the side effects immediately after you start a new medication, and then sometimes with each dose increase, you'll have side effects. But most of the time, they'll wear off within a week or two. And as you're doing this gradual dose titration, we're moving up to try to get to that therapeutic range. If the side effects become intolerable, we can always cut back. Right? So the dosing is flexible and it's individualized. Like you mentioned before, it's not a one-size-fits-all. Because at any given dose of a single medication, you can have 100-fold difference in the blood levels across different individuals. Right? If you're comparing the people with very, very slow metabolism to the average metabolism to the rapid metabolism, so that the end effect, or even the blood concentrations of these medications, vary widely between different individuals, even at a given dose. So what's more important is not just what the overall dose is; it is is it working for them, right? And what is the balance between positive effects and negative side effects in a given individual?
Yeah, and the ones that most people talk about. I mean, I'm sure you've heard this a million times. Most people, at least from what I've heard, it's weight gain and it's going to be impact and libido.
Mm-hmm. Yeah. So weight gain is not actually that common a side effect with SSRIs. There's some that can do it. So Paxil has definitely been associated with weight gain. Ones like Prozac, Zoloft, and Luvox, some people get weight gain, but it's not the majority of people.
Okay.
Weight gain is actually a pretty uncommon side effect with those. There are other classes of medications that certainly are much bigger offenders in terms of weight gain. Mm-hmm. Some of the mood stabilizers, some of the antipsychotic medications, and so on, much more associated with weight gain. Sexual side effects are common, but they're dose related. So they're more common once we get up to the higher doses. And more often they affect the ability to have an orgasm or ejaculate than they do libido itself. Right? So they certainly, sometimes people will notice decreased libido, but that's not the most common sexual side effect. More commonly, it would be diminished sensation and a longer time or inability to ejaculate for men or to orgasm for women. Now, that can obviously have an effect on libido, right? So libido is much more complicated.
Yes, it can be demoralizing, and it can just get in your head, and yeah.
Right. But libido can also be affected pretty strongly by depression. And so if depression symptoms improve, then sometimes libido improves. So that's a less common one. Erectile dysfunction or arousal dysfunction in women is much less common with these, but it can happen occasionally.
Are there adjuncts for that? Are there things that can be added to it? Or is it more of just either reduce some of that medication or shift over to a different SRI?
Yeah, all three are possible. So those are the different choices, is either cut back on the dose and try to mitigate the side effects if they're too strong, or first of all, we'll just wait them out, because sexual side effects often will diminish over time. So if you just wait several months, they often get better and the body gets more tolerant to them and accommodating to them. But if they're not going away and they're kind of chronic, then yes, cutting back on the dose is one option. If it really looks like you need that dose and cutting back, you're going to lose the effect, then trying to treat the sexual side effects. And there are different medications that can be used to offset those side effects. So medications like Atigon buspirone or Buspar can be effective at reversing the anorgasmia or ejaculatory delay. Adding on Wellbutrin sometimes is effective for improving libido. There are also, those are the kind of longer term medications where we have to take them every day. But there are also kind of antidotes that you can take just at short periods of time. So medications like cyproheptadine or Periactin can temporarily reverse the effect on orgasm or ejaculation. It stays in your system maybe 4 hours or so, but that one can be used at that time in the same way that people will use drugs like Viagra or Cialis for short-term relief of erectile dysfunction. There are medications you can use for short-term relief of anorgasmia or ejaculatory delay as well.
Yeah.
So there are a couple things that can be done. There are some other specific antidotes that people have tried as well that can be effective for improving libido or erectile function.
Yeah. I really appreciate you taking the time to explain all of that, because so often one of the just biggest hurdles to trying medication is this idea that it's going to have this huge impact on someone's life, and they would rather. It's weighing the pros and cons in their life. Is it worth it for them to face those? But again, as you said, it's the main effect, not the side effect, that we're really looking for.
Yeah, and in the vast majority of people, the main effects, the positive effects, greatly outweigh the side effects. Yeah. Side effects can be managed. They're usually temporarily. They're not necessarily reasons to stop a medication. If it turns out that they're just intolerable and they're too severe, sure, then we think about, okay, do we need to switch to a different one that might have a lower rate of that side effect? Do we need to add something to offset the side effects? Do we need to make a dose change? We've got a variety of strategies. So this requires kind of ongoing work and a partnership between the person who's being treated for the disease and taking the medications and the treatment prescriber.
So you've already teed me up perfectly for my next question about how often should someone be communicating with their prescribing doctor about side effects and about the main effects of the medication, especially once they start, and what are the intervals? How often should they be communicating, and what would call for an email or a communication?
Mm-hmm. Yeah, I can tell you what kind of the instructions and framework I usually lay out when I'm seeing patients. When I first start a medication, I almost always will have a follow-up appointment scheduled for 2 or 3 weeks out, right? Because you'll know within the first 2 or 3 weeks what the initial side effects are,
right?
And so are they tolerable or not? Do we need to make a more immediate dose change or stop something if there's some really bad or dramatic side effect? Luckily, that's pretty uncommon, but occasionally it happens. And then what I let people know is even within that 2 to 3 week period, if there's something really bad that's happening, if the side effect is it's causing something really unusual or very severe or intolerable, let me know right away. Right. So email me, call me, leave a message, text me, let me know, because we can often make an adjustment on the fly even before you come in for the next visit.
Yeah.
Each time we do a dose step up, give the same instruction. Okay, here's what to watch out for when we're going up from 50 to 100 on this medication. Mm-hmm. Same thing. If I'm making a change, I'll almost always schedule an appointment 2 to 3 to 4 weeks out and let the person know, contact me in between if there's something really untoward that happens, right?
Yeah.
Typical side effects that we talk about, what are the most common ones? Yeah, they're going to happen. Just wait for them. They'll almost always go away for a while.
Awesome. Yeah. So for someone who's worried about it, be in communication if they're having some of these really weird side effects. I've heard people talk about like headaches, brain fog, just feeling not themselves. And that can be really, that can either be contributing back into an obsession depending on what subtype they may be experiencing, but certainly, communicating with your doctor about what's going on. And if you have any significant concerns, I always tell clients that the psychiatrist would rather hear from you rather than you just discontinuing without telling them.
Yeah. And in general, I mean, one of the reasons why these medications have been, amongst the most heavily prescribed medications throughout the world for the last 30 years is because the balance of positive effects to side effects is pretty good. I mean, if you compare to heart medications, liver medications, epilepsy medications, chemotherapies, they have way more severe side effects, right? And yet people are okay with them because somehow I can tolerate side effects if you're treating my liver disease or heart disease. Oh, but if we were treating my psychiatric disease, I can't tolerate side effects.
Can't deal with that.
There's like a different standard.
Yeah.
And I think most of the side effects are dose related. So if you start low and titrate slowly, particularly for elderly people or for people who are very sensitive to side effects, within the context of OCD and anxiety disorders, people who already have kind of panic symptoms, fears of changes in their body, who are hypervigilant and focusing on physical side effects, or people who have obsessional fears of the medication itself, right? Who are afraid to take things because they've got an exaggerated or obsessional fear of medication, disasters or some terrible damage to themselves. For those people, we're going to be more cautious and go more slowly with the dose titration. So sometimes when people are treated by primary care providers who are not as familiar with the dosing, they might just start out too high. They get bad side effects simply because they started at a too high dose, right? Yeah. Or they did the dose titration way too fast in a person who needs a slower one because they either are slow metabolizer, they're older, they have other medical conditions that might interact, or they're acutely sensitive and hypervigilant about body symptoms. And we see that specifically people with illness, anxiety disorder, panic disorder, and OCD symptoms that have to do with physical problems and side effects.
Yeah. And again, all of that can be dealt with through communication and saying what's going on, because everything can be adjusted and responded to. Yeah.
So good communication is really the key. And sometimes this includes good communication with the therapist as well, because I've had therapists contact me and say, hey, I've been meeting with this patient every week or a couple times a week, and it looks like they're talking about having certain side effects. but I want to let you know that, that they have these because they haven't told you about them yet. And I would thank them, right? The more information, the better.
Yeah. All right. So when should someone then consider shifting from an SRI to an SNRI?
So SNRIs, or serotonin and norepinephrine inhibitors, are usually considered second line. Right? There is some evidence for their efficacy for OCD, but there's not a huge amount of evidence, and it's sort of equivocal. So there are about 3 of these that are commonly used on the market. Venlafaxine, or venlafaxine extended release, XR, which is Effexor. Desvenlafaxine, which is Pristiq. Duloxetine, which is Cymbalta, and then L-Milnacipran or Fetsima, which is not used that often. And these vary a little bit between within those 3 or 4. There are some that are sort of big S, small n, so where the serotonergic effect is still stronger than the norepinephrine effect, and that's like the Effexor and Pristiq. Duloxetine is a little bit more even, roughly 50-50, serotonergic and norepinephrine reuptake inhibition. Fetsima or L-Milnacipran is a little bit more heavy on the norepinephrine side. So with venlafaxine, there's been maybe 4 studies in OCD, and I think 2 of them were positive and 2 of them were no difference from placebo, so it's up in the air. Just in my clinical practice, using these medications over decades, I haven't really found that much difference between the SNRIs and the SSRIs. That in many people, the SNRIs work just as well as the SSRIs, and it really varies. In a given individual, they might do better on a more selective agent. Another individual might do better on a dual-acting agent. So you have to be flexible. And so, to answer your question about when would you think about switching over, I would say if someone has had a couple good trials, let's say 2 or 3 solid, adequate trials of SSRIs and really didn't get a good enough response, or they're just not tolerating them well, and they've tried clomipramine also and either didn't tolerate it or didn't get a good response, then I would shift over, right? So maybe the 3rd or 4th trial might be shifting over to an SNRI like venlafaxine or desvenlafaxine or duloxetine.
Okay. So someone raised the question that is switching over to an SNRI, and if someone has a better response to that, is that indicative of another diagnosis or another issue that may be present? So that was one of the questions that someone had asked.
No, I don't think so, because as I said, there is some evidence for those medications acting for OCD, even just without anything. Like we talked about, OCD rarely travels in a vacuum. It almost always is accompanied by other psychiatric disorders. So in people who also have depression, sometimes the SNRI is better for their depression than the SSRI was. So you get effects on both those disorders rather than just one. Sometimes the person has generalized anxiety or chronic pain, and duloxetine or Cymbalta is FDA approved for fibromyalgia, some other types of chronic, as well as generalized anxiety disorder. So, the reasons to shift in a given individual might depend, number one, on just what their response and side effect pattern has been, but also on what else you're trying to treat. So if somebody has 3 important diagnoses and you're only getting improvement in one, and you still haven't seen improvement in the other 2, then either you might want to add something or shift to a more broadly acting antidepressant.
Yeah. So another concern that people have is the concern that if they get on medication, they're just going to have to be on that medication forever. And I can have two parts to this. One, do these medications stop having an effect after a certain period of time? You hear people are on Prozac for 10 years, but they're not maybe experiencing the same effect. But from the start, some people are worried that if I'm on this, I'm just on this forever. And, are there any, does research suggest any concerns that people should have about being on medication for indefinitely?
Mm-hmm. Yeah, these are, that's one of the most common questions that people ask when I first start talking about medications is, well, do I have to be on this forever, and how long do I have to be on it, right? What's interesting, and I'll often reflect this back to people, is that nobody asks that question when you're coming in for treatment for Parkinson's disease or diabetes or epilepsy. right? If we say, well, yeah, how long do I have to be on this epilepsy medication and when can I get off? It'll be like, well, okay, whenever you want to start seizing again, that's up to you, right? Yeah. If you have diabetes, sure. Or hypothyroidism, if you want to stop your medication, sure. If you want your thyroid function to drop or your blood sugar to rise dramatically if you have diabetes, right? So the same is true with OCD. Is luckily with OCD and other anxiety disorders, and to a lesser extent depression, we have other treatments that also work besides just medication. And sometimes those other treatments, like CBT, specifically exposure and response prevention for OCD, can sometimes be a good effective substitute or alternative treatment as compared to the medication. So the decision of how long somebody has to be on a medication and when it's okay to stop is very individualized. It's going to depend on a number of different factors. Number one, how much of a response have they had from it? Mm-hmm. Number two, do they have an effective substitute? So are they in CBT? Right? The only really effective substitute for medication, for successful medication treatment of OCD is going to be exposure and response prevention. Number three, how bad were their symptoms and how bad did their overall condition get when they weren't on medication? Yeah. Or if they stopped before, if they've started and stopped, because a lot of people have started something and stopped and started. How bad did it get when you were off, right? Mm-hmm. Fourthly, what are the other things that the medications are being used for? So are we not only trying to treat OCD, but we're also trying to treat for the person's recurrent major depression. Mm-hmm. And when they're off antidepressants, their depression gets really bad and they might end up in the hospital or with a suicide attempt. So how severe are the consequences that might occur if you stop? Right. Not only that your OCD might get worse if you don't have a substitute treatment or you weren't a good responder to exposure and response prevention or other CBTs, but also like how debilitated were you? So what's been found is that when you add in and you do a combination of SRI medications and ERP, adding on ERP can reduce the relapse rate down to about 25% in people who stop the medication. If you stop the medication by itself and you don't have ERP, the relapse rate is going to be upwards of 75% within a year or two. Yeah. Right? The vast majority of people will relapse. Mm-hmm. It won't necessarily happen right away because just as the onset of improvement is slow and the medications have to be in your system and making the changes in your brain function over a period of time before you actually feel really better. Well, when you stop the medication, those changes also can take some time. So people will say, like, well, yeah, I stopped it last week and I feel fine. I'm like, okay.
Of course you do.
Yeah, of course you do, because the effect is still there, right? Yeah. But unfortunately, if you wait 2 or 3 months, you're likely to start relapsing. If you wait 6 or 8 months, you're very much likely to relapse unless you have another treatment in place. Right. So some people do need to be on long-term treatment and some people don't, and it depends. Doing ERP certainly can reduce the relapse rate from 75 or 90% down to maybe 20 or 25%, but it doesn't reduce it to zero. Right. So not everybody with OCD can be free of recurrence after they stop medication, even if they get terrific CBT. It's just not always possible. Sometimes you need the medication. And when we're talking about more complicated situations where somebody has multiple disorders, then the risk of what may happen if you stop, so you might have multiple disorders getting worse. Their PTSD might get worse, or their social anxiety might get worse, or their depression might get worse. And the number of things that you're trying to prevent relapse for, right? Right. If you're trying to maintain improvement in 3 or 4 different things, and any one of those might, or all of them might go down south if you stop the medication, then you have a greater impetus to continue the medication. So it's a very individualized decision. It depends on a bunch of different factors, including what other treatment you're getting, including what's happened in the past, the degree of response, right? My initial concern, and for most patients, I think the primary concern should be, let's first get you better, right? Because what happens too often is that there's partial improvement. There's not even full recovery. Right. So I'll tell people, I don't even want to talk about potentially getting off unless you've been near remission or in remission for a minimum of 6 months to a year.
Yeah.
Okay. Once you get to that point, sure, then we'll
talk about it.
But a lot of people don't even get to that point, or it takes a whole lot of time to even get to that point.
Right.
So thinking initially about, well, when can I get off and how long you have to be on this is very, very premature.
Right.
And it's like missing the forest for the trees, right?
Yeah.
You really have to focus on getting better and needing to do anything possible and increasing your odds of improving rather than worrying about what's going to happen later on at some hypothetical point in the future when you've been better for a long time.
Yeah. I love that perspective. Let's wait to see what good looks like, and then we can decide whether or not it's worth it. Yeah. Right. I had my sinus surgery for the second time a bunch of years ago. And my doctor said after that, hey, so you're going to do the sinus irrigation things twice a day for the rest of your life, unless you want to have the surgery again. Mm-hmm. And I went, I'm good. So that's what I do. I take it everywhere. So it's part of your life, but it's part of what helps keep you healthy, keep you working. I think the take home message that people really need to be thinking about OCD in the same way that they think about other long-term, potentially chronic neurological disorders or other organ system disorders, right? They need to approach it in very much the same way as they would approach their liver disease or heart disease or epilepsy or Parkinson's. This OCD, unfortunately, in most people is a chronic disorder. It's mental health is health.
And we want to get it as close to or as far into remission as we can. But even getting there is difficult, right? Much less saying, oh, yeah, well, I can just treat the acute episode and then I can stop. That doesn't work for long-term disorders that are waxing, waning, and frequently recur.
Right. So another main question, I'm trying to be respectful of your time. Do you have a hard out at the top of the hour?
No, I'm okay.
Okay, so all right, I'll still be respectful of your time, and I can take up the rest of the day. All right, another one, and you're doing so. I mean, you're holding through all these questions. Okay, pregnancy and medication. I hear that a lot. Doctors say you got to be off medication. They're concerned about medication. What's your perspective as research show?
Yeah, it's interesting because I was going to bring this up in that context about, when are the times that it is appropriate to think about tapering off medication, right? So pregnancy is one of those times. Where we really have to think about, what are the pros and cons of staying on the medication versus tapering off the medication, and what are the risks involved. And this is where this is the most common clinical or life situation that comes up that prompts this discussion about should I come off, should I not come off. So my general advice is, number one, there has to be a good conversation between somebody's OBGYN, the patient and their family or loved one, and the psychiatrist, and really think through, what are the risks and benefits? So if somebody's had, very severe OCD, and maybe they've had, horrible depression and suicide fixations, or just severe impairment in general in their overall functioning because of their OCD or depression or other, panic disorder or whatever else coexisting disorders, then the risk of coming off is pretty high. And you really have to manage that. So if it's important and the person really wants to try at least to be off of medication, let's say in the first trimester, because that's usually the period of time when the benefits of not being on the medication are highest, because most of the initial organ development is during that time. So a lot of OBGYNs say, let's see if you can get through the first trimester off the medication, and then if depression is getting worse and OCD is getting worse and so on, okay, we can always get you back onto it sometime in the second trimester or third trimester, because then the risks to the fetus will be mitigated. So it's always this balance between what's the potential risk to a developing fetus, and luckily with the SSRIs, those risks are relatively low, right? Okay. So most of the SSRIs have been studied in pregnancy. There's really good data for sertraline, for fluoxetine. I think for paroxetine, there was probably some negative data, so that would probably not be a first choice. Escitalopram looks relatively clean. There's some good data there. Where, yes, first of all, if you think about, okay, what are the risks of being on the medication through a pregnancy to the fetus? There's a small risk of increased likelihood of miscarriages. There's a small risk of increased likelihood of premature births. neither of those is a high risk, right? I mean, miscarriages also are pretty common no matter what.
Right.
So there's a little bit of increase, but it's not a dramatic increase. Same thing with premature births. Sure, those happen, but it's not a dramatic increase if you stay on medication. In terms of the other risks of the fetus, there is also a small risk of what's called primary pulmonary hypertension in the newborn. That's a fairly rare disorder, but there is a somewhat elevated risk with SSRI treatments for a fetus after the child is born. It's a treatable problem if it occurs at all, and usually it's apparent within the immediate neonatal stage, like within the first few weeks.
Fair enough.
It's treatable and it goes away. So overall, the risks of SRI treatment during pregnancy are actually pretty low. They're there, but they're small, they're manageable. And you have to weigh those against the risk of worsening depression, worsening OCD, worsening anxiety disorders, because those also have pretty severe risks on the developing fetus.
Right.
So the risk to the fetal development if a mother is quite depressed or has severe anxiety through the course of the pregnancy, that's also there. That's substantial too. And then postpartum, certainly there's a high risk of either new or worsened depression and OCD symptoms in the perinatal period. So even a little bit before delivery and in the postpartum stage, both. Those are that entire period of time in the late third trimester and postpartum is a high risk time for both mood disorders and OCD symptoms and other anxiety symptoms. So that's the period of time you really, if somebody's been off medication through their pregnancy and made it okay, you have to watch very closely, because that's the risk period where you have to be ready to restart very rapidly if the person takes a downturn in terms of their mood, depression, anxiety, and so on. And that's going to be really critical, especially for the period of time where now you have to take care of a newborn.
Yeah. You mentioned when we talked about getting off medication and titration, if someone is concerned about that first trimester and wanting to be off medication, is it wise to, obviously babies happen and then you can, talk to your doctor about that. But if someone is considering getting pregnant, should they consider that, quitting their medication, titrating off of that 3 months in advance to anticipate that? Yeah.
Yes, that's a good point to bring up. Yes, the more well-planned it can be, the better.
Okay.
So if someone is thinking about it, my spouse and I are thinking about, having a baby within the next year or two or whatever we're going to try. Okay, then we can set up a plan for doing a gradual taper. When these medications are withdrawn, you have to do it very slowly and gradually.
Right.
Because if you do it more rapidly, there's the risk not only of worsening of symptoms, but also the withdrawal side effects. Right? The brain zaps that people talk about, the nausea, the vomiting, or the rapid mood changes. So you set up a plan for more frequent visits and observation and a slow taper over the course of a few months. And you set up, if possible, behavioral therapy, right, to be put in place. And then you monitor and see how it goes. And if the person can be off for a period and then you see, okay, well, are they going to get pregnant? Let's see if that happens. And then you continue following them carefully during the time throughout the pregnancy. Again, if they can have the cognitive behavioral therapy, even as a preventative in some ways, right? Mm-hmm. Just to work on any residual symptoms that are still there, to get people into the flow of doing exposures again. If symptoms start to flare up, they can nip it in the bud because they've got the therapy visit coming up, right? So for all those reasons, that would be the ideal setup. Slow taper in advance with CBT in place, relatively frequent monitoring. So if somebody's been near remission or in remission, I might see them, every 3 or 4 months or something. Mm-hmm. If they're going to do a taper, it's going to need to be much more frequent, or probably, at least every month.
Yeah.
And if they're seeing a therapist more frequently in between, great, because then we've got the whole team involved in doing a careful observation so that any sign of recurrence or symptom flare-ups can be dealt with.
Right. And again, just like titrating up, communication, telling everybody what's going on. Yeah.
Yeah, exactly.
I skipped past a previous question about medication pooping out, not having the same effect over a period of time. Is that a common concern that people should be looking out for?
It's, it happens, but it's not all that common. And when it does occur, when people say, this worked for me for a couple of years and now it's not working anymore, it's unclear as to what that really represents. Does it represent, a true buildup of tolerance to the medication, or is it just a breakthrough symptom, right? Because people can have breakthroughs and relapses even on medication. That can happen in depression, panic disorder, OCD, any variety of symptoms. So what's actually happening? There is some breakthrough of symptoms, and what's the reason? Is it because their physiology changed? Is it because they built up some sort of long-term tolerance? There's no clear data that indicates exactly what's going on. Certainly, with what's called antidepressant poop out or tolerance or tachyphylaxis, it has been reported. Luckily it's not that common. In general, the longer people stay on and the longer they're in remission, the lower their risk of relapse. So is it because they now had a new stressor or something changed that overcame the effect of the medication, or is it the medication effect really wore off? It's hard to know, right? We just don't understand the physiology of that well enough to be able to answer that question. Yeah. But in terms of what to do about it, the first step usually is to simply go up on the dose, right? And see, okay, well, maybe your brain did develop a tolerance, so we'll bump up as long as you're tolerating it okay. If that doesn't work or the side effects are too strong for that, okay, then we think about making a change. Do we need to switch to a different primary medication? Do we need to add on a booster, right, an augmentation? We're still getting a partial effect from the SRI, just not a robust enough effect. Okay, but we don't want to lose that partial effect. It's still pretty good. Then that's the situation where we think about adding on secondary medications or adjunctive medications. Right. And there are about 4 or 5 different classes of those. And the way we pick and choose between them is again, partly based on previous experience, on side effect pattern, and what else is going on. Are there other conditions that are also breaking through, other contraindications? Are there other medical conditions that would make us choose one class of add-ons versus another class of add-ons?
Yeah. So to that end, to kind of shift over into other medications that are often used for anxiety, I hear people talk about benzodiazepines, and people talk about beta blockers. Obviously, they're very, very different. But if you could talk a little bit about the differences between those two and when they might be most effective and why.
Yeah. So one important thing to know is that neither benzodiazepines nor beta blockers are effective treatments by themselves for OCD. And they're not necessarily even that effective as adjunct treatments for OCD. Benzodiazepines, sometimes people do have kind of residual anxiety that you need to treat with benzodiazepines, but the data is not even that strong as for benzodiazepines as adjuncts for people who didn't respond well to SSRIs, as compared to the ones that do have good evidence, like atypical antipsychotics and memantine and some others that we'll talk about. So they're not like high on the list of adjunctive medications for sort of treatment refractory OCD. There's zero evidence for beta blockers at all for treatment refractory OCD. There's very, very limited evidence, if anything, for benzodiazepines for treatment refractory OCD. Where these medications can be more effective is for other anxiety disorders.
So panic disorder, generalized anxiety, that sort of stuff.
Benzodiazepines certainly can be quite effective for panic disorder. They can be, somewhat effective as adjuncts for social anxiety disorder. Beta blockers, again, the track record is pretty mixed. They are not primary anti-panic or for generalized anxiety disorder, or even for social anxiety disorder. They can be used for what we call discrete social anxiety disorder. So if somebody just has performance anxiety or public speaking anxiety, and they're going to do 3 presentations a year, sure, they can take a beta blocker or a benzo or both, short term right before presentation, and it'll calm down their physical symptoms of anxiety. It'll decrease their heart rate and the sweating and the hand tremor and the shaky voice temporarily while it's in your system. And a lot of people will sometimes use beta blockers for that purpose.
I've heard it described as a cup of coffee in reverse.
Yeah.
In a sense.
Yeah, exactly. Yeah. Exactly. Right. So you're toning down your noradrenergic system. So you get fewer of those adrenergic related symptoms, and they can be effective for that. There's no evidence for that sort of PRN use of beta blockers for OCD symptoms. For benzos, yes, they can be effective in the short term for brief flare-ups of anxiety and things like that. I think when I use them, I tend not to use them as PRNs. Like when people say, "Oh, well, if I start panicking, I have my Xanax in my pocket and I'll just take that." Yeah. That sets up a bad cycle. Yeah. Because if you're waiting for your anxiety to get high and you're not using any other techniques to control your anxiety, and then you're just taking the medication to bring it down, all you're doing is reinforcing the effect of the medication, but you didn't actually prevent the next panic attack from happening or the next OCD flare-up from happening. All you did was sort of temporize it when it happened.
Kind of using medication as almost as a compulsion.
Yeah, or a Band-Aid, or just
Band-Aid, yeah.
Rather than doing the more fundamental work that's required to actually prevent the next flare-up.
Yeah. And for anybody who's new to the medication world, PRN means as needed.
Yes.
So it's, it's one of those medications. It's like panic attack happens. You can take this medication. It's fast acting, but not long lasting. Even though for some ridiculous reason, I hear people talk about a psychiatrist prescribing that as a benzo as a regular medication to take as if it were an SSRI.
Yeah, so that is, if and when I prescribe benzodiazepines, it's usually on an ongoing basis rather than the PRN. Because let's suppose, and this is only in specific circumstances, let's say if someone has pretty severe daily anxiety that's just not getting better enough with the SSRI or the other adjunctive treatments, or they have ongoing frequent panic attacks. And the panic attacks are just not getting better enough with the SRI or other anti-panic medications. Then in those situations, taking a daily prescribed standing dose of a long-acting benzodiazepine, not short-acting ones, a long-acting one like clonazepam.
And it sounds like that's a big difference. That's a significant difference.
Yeah.
Okay.
Yeah. So I almost never prescribe Xanax or Ativan because they're too short-acting. Those would only be for people who need it twice a year or something like that for, very unusual, rare circumstances. But when people are in the middle of ongoing severe anxiety, either severe daily general anxiety or ongoing panic symptoms and panic attacks, then rather than trying to use a PRN, you have to take the PRN 3 times a day. That doesn't make any sense.
No.
Your goal is to prevent further panic attacks and to bring down the standing daily level of anxiety. It's better to use a longer acting benzodiazepine, so clonazepam or Klonopin stays in the system a good 8 to 12 hours. So we'll do a standing dose, a small amount in the morning, a small amount at night, have a consistent blood level, get control of the person's ongoing very, very severe anxiety and panic. And then that can be maintained for a period of time. The goal in the future would be to eventually taper those off once the overall condition is better, once they've had their behavioral therapy or you've made other medication changes to get control of that anxiety. Once they're better, we could do a taper. But I think long-term benzodiazepines or long-acting ones are better used that way than the PRNs. I think too many people have PRN benzos and then they run into trouble. Either they get addicted.
Addiction concerns for that.
Build up tolerance, or they're using them inappropriately, or they're having to use them all the time very often because they don't have good control of their daily symptoms.
And someone in that situation where they find themselves, a doctor might have prescribed a Xanax for a specific purpose, but they find themselves continuously using it, is ultimately that person would be better served by considering an SSRI, SNRI?
Yeah. I mean, if they're not on one, yes, that's the obvious thing is to start treatment for whatever the underlying anxiety disorder, OCD, depression, whatever it is, to get that treated with a more effective treatment, right? But if they're already on the effective treatment and they're still having breakthrough symptoms, and so they're having to take their Xanax every day or something because they're still having panic or they're still having big flare-ups of OCD-related anxiety, you still have to go back and then you have to improve the quality of your primary treatments. Yeah. Either make changes in the medications, intensify the behavioral therapy.
Behavioral work, right.
You're right. Some other change that's going to get that under control. Temporarily, if they're needing to take something every day, I might just switch them over to a long-acting daily standing dose and then make the other changes that we need to make, intensify the behavioral therapy, the other medication treatment, with the goal long term of eventually getting them off of the benzoids.
Right. And another one that I had a question about was Topamax. This is one that was rarely brought up, but I'm curious what your take is on that.
So Topamax is topiramate. It is a medication that is originally an anti-epileptic medication, so anticonvulsant. It was used a little bit for bipolar disorder, so it's one of the anticonvulsants that's sometimes used for bipolar disorder. It's not commonly used because it's probably not as effective as some of the other ones, and it has a different side effect profile. It also has the effect of reducing appetite, so it is used for binge eating disorder.
Okay.
Other use for it, sometimes using it for binge eating. And it has some mild anti-anxiety and anti-impulsivity effects. There are some studies, just a couple, I think maybe 3 relatively small randomized controlled trials of topiramate for refractory OCD that were effective, right? So nothing huge, but at least some data. I think 2 or 3 of the studies were positive and 1 was negative. So some data supporting its use as an add-on for refractory OCD, but it would probably be, in a category that would be like farther down on the list, where there are several others that have much better evidence, bigger studies, more definitive studies. With Topamax and lamotrigine, Lamictal is the other anticonvulsant for which there is some data for refractory OCD. So yes, sometimes people will have those added on to see whether they'll boost the effect. You mentioned people using it for anxiety. I'm not aware of much data at all for Topamax for like general anxiety, for social anxiety, for panic. I don't think there's studies there at all.
Yeah. So if anything, it would be an adjunct to SRI, SNRI.
Yeah, a lot of people will have it added on for binge eating, for appetite control, for headaches. So it can be an anti-migraine treatment.
Okay, that makes sense.
So sometimes they've gained weight from the other medications, and they try adding on the Topamax to see whether they'll get better symptom control along with a little decrease in appetite. So, different doctors will add it on for different reasons, but anxiety disorders should not be a primary reason for adding on Topamax because there's virtually no evidence. It's pretty minimal. Maybe a little bit for refractory OCD.
Fair enough. Okay. Well, I suppose I've reached almost all of my questions. Are there any other classes of medication that you think would be worth mentioning or worth talking about in the realm of OCD and anxiety treatment? I'm sure that's such a broad question.
Yeah. So we talked about first line, right, which are the SSRIs and phentermine. We talked about second line, which would include the SNRIs, and it would also include mirtazapine or Remeron. So again, only a little bit of data, only a couple studies of mirtazapine, either by itself or as an adjunct, that were effective, looked positive. And I have had people who have switched over from SRIs or SNRIs to mirtazapine if they couldn't tolerate the SRI side effects. Mirtazapine is a well studied and with a strong evidence base for panic disorder, for general anxiety, for major depression. For OCD, much less evidence, so I put it maybe second line. But it has a completely different pattern of side effects, and so it can sometimes be useful as a switchover or as an add-on because it's kind of, in some ways, the side effects are kind of opposite. Then we get into adjunctive treatment. So these secondary medications that don't work by themselves, but they can work as add-ons to SSRIs for people who just didn't get an adequate response to the SSRIs. And there are about 4 or 5 different categories of those. So number 1 would be the atypical antipsychotics, things like aripiprazole or Abilify, risperidone or Risperdal, quetiapine or Seroquel, and then some of the newer ones like brexpiprazole or cariprazine. Unfortunately, the newer ones, they might be a little bit better in terms of side effect profile, but most of them haven't been well studied for OCD. So lorazepam or Latuda, it's well studied for bipolar depression, for unipolar depression even. There's only like 1 or 2 case reports of a couple patients. So we just don't know how well it's going to work for OCD. Rexpiprazole or Rexulti, there's like 1 open trial, I think, successful for OCD. For the other newer ones, nothing more than case reports. So we simply don't know. We expect that those should work about the same as Abilify or risperidone did, maybe better tolerated, but we don't know that because they haven't been studied. So that's category number one. Number two would be the anti-glutamate or glutamate modulator drugs. And the one that's used most frequently here is memantine or Namenda. And there's quite a bit of literature on Namenda, numerous controlled studies showing that it can be effective for probably a subgroup of people with OCD that didn't respond adequately to SSRIs. And it's relatively well tolerated and generally doesn't have that much in the way of side effects. Its primary use and primary FDA indication is for treatment of Alzheimer's and other dementias. But what we found is that it can be an effective adjunct for OCD, and even by itself, it can be an effective treatment for body-focused repetitive behaviors. So trichotillomania, skin-picking disorder, hair pulling, other BFRBs. There's a good solid study, a randomized controlled trial for BFRBs, and memantine was quite superior to placebo. So that can be another reason to use memantine. The other pretty commonly used glutamate modulator is an over-the-counter one called NAC, right? N-acetylcysteine, NAC. You can get that in the health food stores or order it online. And the data is not super strong. Again, there's like some positive studies and some negative studies. So it probably is helpful for some people. It's not clear how big a proportion will be helpful for, but that's an easy one for people to try. I haven't been all that impressed by its effects in the patients that I've had, but some folks have reported that it's been helpful for them. Again, very easy to tolerate, doesn't have much in the way of side effects. People can get it without a prescription, so it's a reasonable thing as an add-on.
Easy step in.
Easy step. It's also another one that has a little bit of evidence for the BFRBs.
Oh, that's great to know. That's good to know.
So there might be reasons, but I wouldn't expect any major giant improvements from NAC or, frankly, for memantine for that matter.
Yeah. I've heard some clients have the obstacle of just the word antipsychotic, as if what they're experiencing is a psychotic disorder. And certainly, I can imagine some of these antiglutamates you're talking about were prescribed. You said mostly for Alzheimer's. I'm sure that also has a particular stank to it for some people, or I guess stigma is the right way to say it.
Yeah. And I think it's important for people to know that medications often get labeled by whatever they were initially developed for. Right. But when we're using them in other now, drugs like Abilify are used much more often as add-ons for refractory depression than they are for schizophrenia or bipolar disorder, simply because those are much less common, right? There's a lot of people, millions of people with refractory depression. Schizophrenia and bipolar disorder only affect maybe 1 to 1.5% of the population each. And when we use these medications as add-ons in OCD, we're using them at much smaller doses. So it would be better to classify these medications on the basis of their biochemical action. So it would be better to call them dopamine modulators or dopamine receptor antagonists, right? Rather than using the term antipsychotics. That's when they were originally developed, but it's clear that they have effects in so many other conditions.
And is this your fight with the FDA, is what I'm hearing?
No, it's not really with the FDA. It's more in terms of the drug companies and the people who kind of create classifications. Yeah. So there's a whole push within psychopharmacology to change the names and the categories of drugs really to just their biochemical actions, right? So instead of saying antidepressants, that's also a misnomer because most of the antidepressants are also effective for a whole variety of other conditions. SSRIs are effective for almost all the anxiety disorders and OCD and depression. So they're clearly not just antidepressants, right?
Right.
We just say they're SSRIs, right? Just,
this is what they do.
Calcium channel blockers, beta blockers, right? GLP-1 agonists, right? We're not saying anti-weight loss drugs. We call them GLP-1 drugs because that's their mechanism of action. They work on glucagon-like peptide. Right. And so it's better to classify these drugs based on their neurochemical action. So instead of calling them antipsychotics, we can call them like dopamine, serotonin receptor antagonists. It's just more complicated, but that would be more accurate.
Yeah.
So those two classes, and then there's some others. Ondansetron, which is the brand name is Zofran. It's an anti-nausea drug, but actually it's a serotonin 3 receptor antagonist, and it doesn't just work for nausea, it also decreases anxiety. And so there's been a number of controlled trials showing that adding on ondansetron for refractory OCD can be helpful.
How's that for emetophobia?
It decreases nausea. So whether decreasing nausea itself would help for the fear of nausea is not clear.
Okay.
In fact, if we're going to do exposures, what you actually want to do is to get
create that nausea,
to be able to experience nausea without being afraid of it.
That's
right. So
a valid point.
Yeah. So it probably would work at counter purposes.
Yeah. Good point.
Yeah. If, on the other hand, people are actually suffering from nausea from their SSRIs or other treatments, then it's good.
Different story. Yeah.
Yeah. And even without the nausea, just as an add-on for refractory OCD, it can be effective. And it doesn't have sexual side effects, and it doesn't cause weight gain. So it's beneficial from those ways. It doesn't really have much in the way of interactions with other drugs, so it's easier to use. The one big side effect it can cause is constipation.
Downsides.
Yeah. So if somebody has, let's say, IBS with loose stools or bowel urgency, okay, well then that's good.
Yeah.
If somebody has constipation commonly, then I wouldn't use it.
Yeah. And again, this would be something that you would look into either as a supplement or a augmentation, or as something that, wouldn't be, if SSRIs aren't creating the effect that you'd want, you might kind of go down this list.
Yeah. And these are all add-on drugs. They don't work by themselves. So,
there we go.
Right. So Abilify and other atypical antipsychotics don't work by themselves for OCD. Mood stabilizers like lamotrigine and topiramate don't work by themselves. They may work as add-ons. Memantine, NAC, don't work by themselves. They may work as add-ons. Ondansetron, same thing. Doesn't work by itself. Might work as an add-on.
Perfect. You said there was one more? One more category? We hit all the categories.
Really, those are the major ones I would think about. Yeah.
Okay.
Everything else is sort of experimental, still in study, things like ketamine. Right, so people out there are getting IV ketamine now, and there's really just 2 small controlled trials that were positive for ketamine with a total of, maybe 25 or 30 people. That's it. Yeah. So there is a whole lot more work to do. Unfortunately, ketamine clinics have just popped up all around the country. They're everywhere. People are going in looking for, rapid relief.
Right.
And there's just not nearly enough known.
How about TMS? I'm sorry. Go ahead.
Both of those, right. The database for TMS and ketamine is much stronger for depression. We've had studies for 15 years plus of ketamine and TMS for depression. But in OCD, very limited data. Looks kind of promising, but there was also one negative study. With TMS, there's been a bunch of different studies around the world showing TMS can be effective, but the amount of effect is unclear. The duration of effect is unclear. It looks like it's a temporary treatment. So then what do? Do you have to do monthly TMSs? Do you have to do weekly TMSs? You have to go back for another course? It's not clear exactly. So it's a neuromodulation treatment that's kind of lower on the list with some of the other neuromodulation treatments like deep brain stimulation or the neurosurgical approaches. Yeah. So it can still be helpful, and TMS is widely available, and there is a type of TMS that is FDA approved for OCD, but I usually would reserve it for people who either hadn't responded well to a number of different medication combinations or couldn't tolerate them and didn't respond well to intensive behavioral therapy.
Yeah. These things are not tier 1, try first things. Now they're
not even tier 2 or 3. They're more like tier 4.
Yeah, way down. So we're also you're in San Diego, so we're in a weed state. What's the effect of marijuana on anxiety, OCD? And I know there's some talk about psychedelic use, but I know that's a little wigglier even. But what's your experience with those? Because I know someone out there is asking this question.
Oh, sure. Yeah, no. There's a huge interest in all the psychedelics, not just in the layperson community, but in the scientific community.
Yeah. I
was just at, a major scientific conference, a few weeks back, and there were lots of panels and posters on psychedelics. There are ongoing studies for OCD. Chris Pittenger at Yale, they have a study going, Carolyn Rodriguez and colleagues at Stanford. So there's a number of ongoing psychedelic studies in OCD. They presented at the conference in July.
I went to that one. It was great.
Yeah. And so the initial results, kind of the preliminary results actually look pretty good. But it's going to need full trials to really see. And those are primarily with psilocybin. I don't know that anybody's done like an MDMA study. But psilocybin, the depression studies and the PTSD studies look pretty good. And that data, that sort of body of evidence has been building now for 3 or 4 years. With OCD, it's still really early. And I think there's one brief trial in body dysmorphic disorder done by Jamie Fusner and colleagues in Toronto that actually looked pretty good too. But it's going to be a while, a few years minimum before we really know whether these are going to be helpful and whether then they can be appropriate for FDA approval at that point.
And I bet that'll be a hard road because I'm sure to get up and over that hurdle to say that a psychedelic is going to be used medicinally is probably hard.
I don't think it'll be as hard as it would be for the CBD or THC or marijuana or something like that, and simply because the forms of psychedelics that are being used are very purified. And I think the critical thing is not so much getting over FDA hurdles. The critical thing is to make sure that you don't get adverse effects and that you're selecting the population correctly, because anybody who's at risk for developing psychotic symptoms or bad dissociative symptoms is not a good candidate for psychedelics. And so they can produce really, really bad outcomes in people who are vulnerable. So you have to be really, really careful. The other hard part in the psychedelic research is that it's very hard to do any sort of blinded studies. You can't do a double-blind study because everybody knows whether they're getting a psychedelic or not getting a psychedelic, right? So trying to find a good placebo where you'd actually take care of, like, okay, I'm not sure what I'm getting. Maybe it's placebo, maybe it's not. It's very hard to do with drugs that have such a strong initial effect of psychedelic experiences or dissociative experiences. So it's hard to create a true blind, double-blinded study, much in the same way as with psychotherapy research, right? But it's very hard to have a double-blind psychotherapy research unless you compare the psychotherapy to pill placebo, and too few studies do that. So most of them are, they're studies compared to a wait list. Well, nobody thinks that they're going to get better on a wait list. It's clearly not a blinded thing.
Right.
It's not a fair comparison. It's like people who know they're getting nothing compared to people who know they're getting something. Yeah. Right? Of course there's going to be a difference. Everything looks better than a wait list. Wait list is not a great placebo, but pill placebos could be good. But so it's the same issue with these. If you have the active drug it has such a strong initial reaction and such a characteristic one, then how do you get a placebo version of that? So that's what people are trying to figure out.
I can imagine that's a huge struggle.
With marijuana or any THC compound or CBD, those studies are ongoing. There are some people who will temporarily report relief of their OCD symptoms and they smoke pot or take an edible. The problem is it's temporary. And looks like is that long-term use ends up worsening your OCD, your mood disorders, and anxiety disorders. So when people are using every day, and there's a lot of habitual daily or edible or vapors or edible users. And what in the studies of them looking long term over a year or more, they get worse.
Right.
And even people who temporarily get relief, oftentimes the next day they're worse. So, like people's anxiety will go down when they drink, but the next day they're often worse.
Right.
It's the same thing I frequently see with cannabis products.
As I say,
they temporarily relieve anxiety in some people. In some people, they get panic attacks. But for some people, they're calming. But the problem is that effect doesn't last, and you may set up a cycle where you worsen your underlying disorder over time. And that's what the data looks like.
And that's the problem with it. Yeah, you're borrowing happiness from tomorrow, as they say.
Yep. Yeah, that's a great way of putting it.
Yep. So my last question is what medications or research that's on the horizon are you excited about or interested in?
Yeah, there's quite a bit on the horizon. I think we're going to find out a lot more about the psychedelics over the next years, and we'll see what they're effective for, what they aren't effective for. The reason they're exciting is because in many of the studies, a single dose ends up producing long-term effects. And now what they're studying are not psilocybin, but other synthetic molecules that mimic some of the effects of psilocybin or MDMA. So they have various different effects on serotonin receptors that are similar to what you see in psilocybin. And what they're trying to see if they can develop drugs that can be given at a single dose and then work for a month, and with substantial improvement in depression symptoms.
That would be amazing.
Yeah, and the preliminary data looks pretty good.
Wow.
And so we'll see. So I'm excited about that whole field of psychedelics, both the psilocybin and MDMA, as well as some newer synthetic ones, There's a couple that can be inhaled or nasal spray versions rather than taking a pill.
Yeah.
And then the whole class of glutamate drugs. So ketamine and S-ketamine or Spravato are the ones that are currently available, but drug companies are studying a whole bunch of other different glutamate modulating medications. And theoretically, those should have promise for OCD because there is evidence of elevated glutamate transmission in certain circuits in OCD. I think trying to find ones that will improve glutamate function or diminish glutamate function where it's excessive without diminishing glutamate function everywhere else in the brain where you need it, that's going to be the tricky part. And also finding treatments that work long term. Like even if ketamine works, it's a short term
temporary.
It's temporary.
Yeah.
So for people with severe depression, suicidality, it can be a lifesaver. It's a true lifesaver. We'll see what happens with OCD. So far in those initial studies, it looked pretty good. Single dose effects decreased OCD symptoms substantially, not for every person in the study, but for a fair number of them. And it lasted for about 4 to 7 days, and then it wore off.
Yeah.
So we'll see if that bears out, and we can find which populations benefit from that. If we can find markers of who will respond better to which adjunctive treatment, that kind of research, I think, will move us into the future.
That's amazing. Well, it'll be exciting to see what's on the horizon, which is going to continue to come out next as research continues. And I know that you're presenting something at the conference coming up this summer, if I understood that correctly from our earlier conversation.
Yeah, I don't have any medication studies. What I'm going to be presenting or putting in a submission for presentation will be the results of our big electronic medical record study that was published in the white paper. We sent that around to people. I can send you a copy if you didn't get it. But we've been trying to actually disseminate it pretty widely because this was the largest study of OCD ever done. The database had 10 million people from health centers all across the country.
That's an insane number of people for a study.
Of those, 72,000 were identified as either having the diagnosis of OCD or their notes indicated that they probably had OCD just based on the notes. That says, patient reports that he was diagnosed with OCD and is getting therapy for it, but it just wasn't reflected in the diagnosis list because it was a primary care visit or a surgery visit or something, and they weren't going to list the psychiatric diagnoses. So of that 72,000, number one, that was way lower than what it should have been. So it indicates that maybe 3/4 or more of people who actually do have OCD are not getting detected or diagnosed within the healthcare system.
Based on previous population percentages, et cetera?
Yeah, exactly. So the rough percentage of the population that has OCD is somewhere between 2.5% and 3% of the population. And yet what we found is that only 0.5% of this 10 million person database was actually formally diagnosed with OCD. And then there was another 0.2% that was detected through the note content with an AI search. So even so, it ends up being like less than 0.7%, which is only about a quarter of what it really should be. So right away, we know people aren't screening, or folks aren't talking to their healthcare providers about their OCD, or they're telling them, but they're getting diagnosed with something else.
Right.
Getting just called depression, or general anxiety, or anxiety not otherwise specified, or something else, which means then they end up not getting the right treatment. Even worse is that of that 72,000 who actually were detected or formally diagnosed, only a quarter of them, actually I think only 19%, got CBT. And that CBT may or may not have included exposure and response prevention. Only 2% had actual documentation of getting exposure and response prevention. 2%. And even if we say, okay, well, maybe the other ones where the chart just listed CBT, maybe they were getting exposure and response prevention. We wouldn't expect the primary care doc or the psychiatrist to necessarily specify. They might just say, yeah, patients receiving CBT. Okay. Even giving that the benefit of the doubt, it's still only 19%. It should have been 100%.
Right.
And more than half of the OCD patients in that 72,000 did actually have documented mental health evaluations that were in the record, and still they weren't getting referred. So only less than a quarter of that overall 72,000 even got a referral for any type of CBT, ERP or otherwise.
Right.
They were referred for like talk therapy or supportive therapy or no therapy.
Right.
So this is a serious problem. This is the huge gap that we're seeing. It's a big gap in diagnosis, even when they're diagnosed or detected and
referral
evaluated by a mental health provider, they're still not even getting referred for evidence-based treatment.
Yeah.
Right? And so what ends up being is that a tiny minority, maybe it's 5% of the overall population of people with OCD in the country are actually getting evidence-based psychotherapy. So people, so it's a failure at all different levels: screening, diagnosis, and then referral and provision of the adequate treatment. Right. There's no reason why, if somebody's getting a mental health evaluation, that you shouldn't refer them for CBT or do the CBT if you're a therapist, and yet they don't do it. Right?
And here we are.
We know lots of therapists out in the community who know, if they look at a textbook, that exposure and response prevention is the appropriate treatment for OCD, and they still don't want to do it.
Right. Oh. Well, if hopefully that paper does get accepted and you can present that or share that, but I've asked all the questions and you've gone through everything. I appreciate this as a tremendous resource to people who are looking for information about medication. And this is just a little bit of information that's out there, but this is a great start for people. Is there anything else that you'd want to add at the tail end of this, to give people something to think about, or an element of encouragement, or just thoughts at the end of this?
Well, I think number one, OCD is quite treatable, and medications do work for the vast majority. Yeah. Any single given trial of an SSRI, about maybe 60% of people will respond. If you do serial trials, like if the first one didn't work, you go to the second or the third, you can get that response rate up to a higher number, maybe 70%. If you use adjunctive treatments, you can get it even higher. But the medications by themselves rarely will result in remission of symptoms, right? You get a partial response. So almost always you're going to need to combine it with the appropriate CBT. But so I think combination treatment is by far going to be the most effective for the largest group of people, especially if they have more than one thing going on. A good resource is the treatment guidelines that we developed over the last couple of years and posted on the International OCD Foundation website over the summer. So those guidelines are written for lay people, family members and sufferers of OCD, as well as for sort of beginning clinicians who may not have that much experience with treatment of OCD. And so it goes through all the different psychotherapies that have been tested and tried for OCD, the primary ones, the adjunctive ones, and it goes through there's articles on medication treatment. It's a great resource. It's pretty comprehensive. And it's on the website for anybody to take a look at, the OCD treatment guidelines.
Love it. I'll try to find that webpage and tack it on to the episode page for this, for people who are looking for that information. Just share the link with people so they can take a look. But that, I think, is a really helpful resource. It was, compiled by numerous people who are on the Scientific and Clinical Advisory Board or who have other psychotherapy expertise with OCD, even if they're not on the Scientific and Clinical Advisory Board. So it was a pretty broad range of authors who contributed articles for that treatment guidance. That'll be amazing. So awesome. Well, Doctor, thank you so much for spending the time with us today and sharing all this information. Where can people find more information about you or your work? I'm listed on the staff listing on the International OCD Foundation webpage, or I also have a practice, the San Diego Center for OCD and Related Disorders. So people can contact me by phone or by email, or they can look at the profile on LinkedIn or Doximity. Either one of those will explain, kind of has my biography and my practice information and contact info. Awesome. Well, again, thank you so much for your time, and have a great day.
Thanks so much for having me, and I hope this will be helpful for people.
Absolutely.
Take care, Kevin.
Take care. Thank you for listening to the Fearcast. If you would like your question answered on a future episode, please click on the Submit a Question link at fearcastpodcast.com. If you would like your question answered sooner, please send me a recording of your question to questions@fearcastpodcast.com, or by sending me an audio message through Instagram by DMing me at fearcastpodcast on Instagram. If you like the Fearcast, please write a review on your podcast platform of choice. Please remember that the Fearcast is not a substitute for psychotherapy. If you need a little bit of help in your recovery, please go over to fearcastpodcast.com and click on the Find Help link, and there's going to be some information for you there. So until next time, take a risk, challenge yourself, and don't take your brain too seriously. Bye.